I'm the token syncope guy here, and so bear with me. Can I just figure out who you all are? How many are allied health professionals? Nurses, occupational PT, okay, about a third. And physicians, the rest? Yeah, okay, 2 to 1. And of the physicians, generalists, so general internists, family doctors, and then the rest are neurologists, pediatricians, psychiatry. I'll take a whack at psychiatry, cardiologists, bit of this and that. Okay, good. So this is the wrong title. The last thing I would ever talk about is non-epileptic seizures. I'm just a simple cardiologist from north of Montana. And the neurologists actually call this psychogenic non-epileptic seizures, PNES. What in the world were they thinking? So we'll get rid of the bad title. This is the real title, and that is the 2 big mimics that you see in your clinics. And there's not much published on these, so I'm not going to bore you with even summarizing them. What I want to do is just give you some simple tips on how to get through an office consult when things seem to be going south and you realize that you're on strange ground. And it happens probably 10 or 20% of the time. So, Heart Rhythm Society, the Syncopal Definition actually came out of a conference held on the shores of Lake Garda, which is next to Lake Como. And it is a definition that was put together by cardiologists and neurologists and emergency doctors and internists and family doctors. And they wanted to get a practical definition that actually worked for everyone. And if you think about it, this is the one that actually is closest to the one that you use. When you're trying to decide if somebody has something, what you do is you say, well, you know, could be this, probably this is what it is. And that's what this definition, it says, you know, these are the things to look for. And by the way, they probably don't have the other stuff. And so the last one is important. And the last one is the one that's tripping us up today. The absence of clinical features specific for another form of transient loss of consciousness, such as an epileptic seizure. There is a bit of help. There are 3 papers here. There are a few cardiologists here, so you'll know about these and the rest won't. But there are now 3 consensus conference guidelines and formal society guidelines, 2 from North America and 1 from Europe in the last 4 years. And the European one is really accessible and beautifully written. If I had to recommend one for bedtime sleeping, that would be the one. The others are more practical and punchier. So first question is it truly syncope? Well, in the European, is Arthur here? No, good. So in the European guidelines, there actually is a list of a half a dozen things that you have to consider with transient loss of consciousness when you're deciding whether or not it's syncope. And one of them is sleep and coma. The Europeans are really concerned that you'll confuse syncope with sleep or coma. But the ones that are the problems in North America are epilepsy, pseudosyncope, and falls versus faints. And falls and faints, it's really the older population, so we won't really deal with them today. But we're going to deal with epileptic convulsions and pseudosyncope. So, is it apparently epilepsy? This is the kind of EEG that catches people's attention. But if you look in the very top, that very top line, you'll see whoever it is that was working there had a very bad day because they wrote down jerks. But in fact, I think what they meant was shaking and convulsing and thrashing about. And then the next 5 lines, if this was a Holter, we'd say bad contact. Don't trust this, but the neurologists are happy looking at this. And you can see starting on the left is some very fine activity, probably some alpha, and then there's some sort of more undulating stuff underneath it. The beta stuff, sorry, neurologist, is a cardiologist up here. And then things start to fall apart. And then between the 2 really sort of coarse, high amplitude things, it's actually flat for a while. And that's what happens during syncope on the average. We published something like this about 25 years ago. In fact, it's more varied, but things always slow down and often they stop. And if you look on the bottom two lines, you see what really happens in vasovagal syncope, and that is that hypotension starts first. You see the top line, which is blood pressure, starts to dribble out, and things sort of hang in there for a while, and this is actually what happens a lot. Things hang in there for a while. Patient feels crummy. This is when they should be lying down. And then there's a quick big puff of acetylcholine, and they become a little asystolic there, and then faint. And so that's the common faint causing some jerks. So how common is this, and why is it a problem? Because surely everybody can tell epilepsy from a couple of jerks. And the answer is it's inevitable that it's a problem. And it's inevitable because over 50% of people have faint at least once in their life. And it's a power law, right? So the median is around 3. It's a recurring thing that goes on and on. There's a lot of it around. And so convulsive syncope is common. I'll get to how common it is later on. Epilepsy, though, epilepsy has about the lifetime cumulative incidence. It's about 1/100th that of syncope. And what that means is no matter how good anybody or any system is at diagnosis, this is a problem, because a tiny amount of misdiagnosis of the syncope is going to vastly inflate the apparent diagnosis of epilepsy. And what's amazing is just how well people do. So if you look at what the actual misdiagnosis rates are, there have been half a dozen papers published now looking at misdiagnosis rates in specific clinics and areas. And on the whole, about 20 to 25% of epileptics are misdiagnosed. They've got something else. Psychogenic non-epileptic seizures, syncope, other stuff. Which is really a very low, it sounds like it's high, but it's a very low proportion considering what the neurologists are faced with. Of that 25%, somewhere between half and all, probably half, is actually syncope. And even that's not as bad as it seems. How common is it? Well, casual observers, if all of us were to faint and somebody were to, a hotel employee were to walk by, would say about 10% of us are actually shaking and probably have epilepsy. So that's common. How common is it really? If you do a videometric analysis, the Dutch have time to do this, and you look at tilt tests frame by frame by frame, 70 to 90% of people have a bit of myoclonus. Often it's just upward deviation. It's myoclonus. So those are the magnitudes of the problems. What is myoclonus? What do you actually see? The easy stuff is what we remember, and that is sort of brief, extensive rigidity. It's what you see on tilt tests all the time. Bit of brief rigidity, bit of shaking, and then after about 5 or 10 seconds, they're back down. Upward gaze, fixed gaze, the lights are on, but nobody's home. Stiff neck. This is easy to sort out, and nobody would confuse it. The problem is that if you compile all the papers, which he did a while ago, that it's much more complicated than that. What fainters do is all over the place. And a lot of it looks like the bottom line. They just look like they're thrashing about and not making a lot of sense of it. So that's the magnitude of the problem. Are there any good signs? One of them is tongue biting, right? So lateral tongue biting, bite the edge of your tongue, not the tip. So tongue biting has, if you pick it up in the history, has an odds ratio of 12. Right? So if you can pick up lateral tongue biting, this almost definitely is not convulsive syncope. It's not that sensitive, it's highly specific. A lot of this stuff you can find in papers. I really don't like it when people show these, so I thought I'd show them all at once and get them over with. There, memorize, it'll be a test, okay? But and these slides are, open access. But you can get these, it's a little review we did a few years ago. But you can get all this stuff in that review if you want it. But there are the slides. memorize them. Now comes the practical stuff. So the neurologist you can go to sleep now. But for the rest of us, this is kind of strange ground for us. And so we've worked out ways to do this in Calgary. And it came out of the two rules that I've learned about teaching residents and medical students how to read an EEG. And they always get stuck on something, somewhere. And it's always a place where they can't figure things out. So the first point is, don't look there anymore. It just drives you crazy. Right? So if you don't understand something, don't look at it anymore. Go look somewhere else. And so when the patient's saying something that doesn't make any sense, just go do something else for a while. And then come back to that, and you'll have sorted it out. And then the second thing is look for the odd stuff. The nurses really like to put nice, clean rhythm strips on charts, right? So they clip out all the good bits. And they put and so what I teach the kids is dumpster dive. Often you have to go you got to go in the garbage to get the ECG strips that make sense. I couldn't make this up, right? So if you're confused, don't start with what you're confused about. Go back, way back in the history. If they've got convulsive syncope, they almost certainly will have fainted at other times. So go back and learn about their faints. Take a detailed history about stuff that you're sure is just a faint. You know, they were 17 and they gave blood for the first time and they fainted. And figure out what they felt like before, what they looked like during, what they felt like afterwards. So you're building a pattern for the patient. And then you go on to what those particular things look like. So for the uncertain ones, where you're not sure if it's convulsive syncope or epilepsy, take a history around that and the usual stuff, previous history of epilepsy, whether they've been worked up, brain imaging, stuff like that. And then I think what you'll find almost all the time, and we get referrals from neurologists, and almost all the time, you can map or not map what they had to what they had, and that will get you out of a lot of trouble. And if it doesn't get you out of trouble, you're in real trouble because nothing works. Basically, you may say, well, let's just do a tilt table test. The problem is, if you're confused about them, you're probably confused about them because they've already fainted at some point. Most of that's vasovagal syncope, so the tilt test probably is going to be positive, and it won't help you. And if it's negative, it won't help you. If you put in a loop recorder, one of these tiny little things you can just inject at the lifetime cost of $5,000 or $10,000 without providing any therapy. So if you just inject these in and you get sinus rhythm during a spell, what have you learned? Almost nothing. It could be just vasodepression without any particular sinus bradycardia. Could be pseudosyncope, could be epilepsy, and so they don't really help you. EEG, somebody's already done it. Ambulatory EEG won't catch syncope because it doesn't happen that often. And if you send them to a seizure monitoring unit, again, the nurses are really nice and helpful and they keep them in bed, so they're not going to faint. Okay, psychogenic pseudosyncope. Sometimes you take a detour in life. I want to tell you 3 quick stories. So one is, these are true stories, but I won't tell you their names. One is a 23-year-old, she'd fainted a few times as a kid, and then nothing happened, and then she was truly bipolar, not Hollywood internet bipolar, she was real bipolar. And she was admitted involuntarily. She got better. Her doctors didn't believe she was better. She couldn't get out, and she started dropping 10 or 20 times a day. And eventually they decided she was too crazy for them and discharged her. And then she stopped. Okay, so there's a stress. She's trapped. She starts going down a lot. Stress is relieved, and she stopped. Second, 27-year-old man, really kind of a B-type personality, nice, affable, low-key, not very ambitious kind of guy. Worked in a pipe factory carrying heavy pipes, hated it. Started fainting a lot, but never when he carried a pipe. And so eventually his mom, who managed the McDonald's, said, just come work with me. It all stopped. She got sick. He became the manager. Everybody who's ever had people reporting to them know what happened. He hated disciplining people, started going down a lot. She said, oh, for God's sake, went back to work and it stopped. Third true story, late middle-aged woman, terrible, 4 years of awful, awful, awful breast cancer. Finally, it sort of petered out. She got well enough to work, and then she started going down all the time. And it took us a little while. I was just learning how to do this. It took us a little while to figure it out. But eventually her husband got a pulse. They came back to the clinic. Her husband said, I thought you said they had to have low blood pressure when they fainted. I said, that's true. And she said, I don't want to go back to work. So he said, don't. We have lots of money. And she stopped. That was not faking it, by the way. So these are conversion syndromes. A psychologist, psychiatrist know all about them. It's some kind of psychological stress, but it's not just stress in our patients. They are trapped, intractably trapped in a terrible situation. The neurologists are comfortable dealing with this. Cardiologists, it's very foreign to us. The thing is, though, that words count when dealing with our patients. And we've been calling this psychogenic pseudosyncope, and try to think about what that would sound like. If someone said to you, you have psychogenic pseudosyncope, you're crazy, you're faking it, you have and are the problem, and you should not be in my office. And so we need a new name for this. We have to get rid of this psychogenic pseudo stuff. So you think in 2 words, we're giving 3 wrong messages. Psycho, so you're crazy, but they're not. They're trapped. Pseudo, so you're faking it. And psychogenic pseudosyncope, you say it quickly enough, it's just garbage. Nobody understands what you're saying. So what we need is non-biological collapse. We don't even have a definition for this syndrome, but it's common. It's probably 10% of our patients. It's a syndrome of apparent loss of consciousness in the absence of demonstrable cerebral dysfunction. This covers epilepsy as well. So, words count. You're not crazy. You have a problem. It's happening to you. We can work together on this. There's some things NBC is not. NBC is not a not very bright bird with lots of feathers. I had a patient who had 40 of them, and we had a quick cold snap in Alberta, and they were too stupid to come inside, and all their little feet fell off. So he had to kill. I know, NBC. NBC is not a diagnosis of exclusion. I'll show you how to make the diagnosis. It is not, I can't figure out what's going on, they must be crazy. It is, these are the things I'm looking for to rule in this conversion syndrome. It's not malingering, right? These people really think that they're going down, and they don't have Munchausen's. How common is it? It's probably 10%. It depends on the age of your clinic population. If they're in their 60s and 70s, it's very uncommon. Young people, it's quite common. There are 3 patterns that we've seen. The first are people who've had a couple or 3 little warning faints when they're kids, usually fairly close together, and it's true of biological syncope of some kind. Nothing happens for decades, something happens, and then because of our wait list, it's been going on for at least 3 months when we see them. Second type, much less common, a few warning faints, nothing happens, and then something has happened. And they're much worse for a short period of time, like that bipolar woman. They're worse for a few days, and then they get better. And the third are much more difficult. And these are ones who they have months to years of syncope. You spend the first half hour knowing what to do, and you still can't figure it out. And it's high frequency, long duration stuff. It's very vague. And after half an hour, if you haven't figured it out, they have type 3. Because you can't figure it out. Because most of this is very straightforward stuff. So signs, sweating, pallor, common in vasovagal syncope, doesn't exist in non-biological collapse. Eyes are closed. Everybody knows your eyes are closed when you faint, so their eyes are closed. And they go down, one of my patients said they went down like a sweet angel. What are the kinds of chronic stresses? This is horrible stuff. This is not, I forgot my homework. This is horrible stuff. This is long-standing family abuse, broken families, anger everywhere, sexual assault, repeated sexual assault that the police ignore, terrible workplace stress. For the women, it's mainly sex. The men, it's mainly work, right? Mars and Venus. And then the other stuff is a bit less common. So we now have criteria, and these are all, we'll post them. They're younger, they're mainly women, but I think it's because there's a power differential in society still. Implausibly high frequency, implausibly long duration, and so on. Again, how do you deal with this? Actually, you just stop and listen. The most important thing is just to be quiet for a while and let them work through it, but know where it is you want to go. Okay? The 3 early red flags that pop up, you'll see these red flags in the chart. We flag the charts. We can read, we pick up most of our patients just by looking at the charts when they're coming in. High frequency, so at least once a week. But if it happens several times a day, just rubber stamp, that is the diagnosis. Long duration of the faints, minutes to hours. And history can be, in the type 3s, it's a very vague history. They live in not just an innumerate universe, they live in an inarticulate universe. How do you do this? 1, stop. Listen. Give up. Your clinic is disaster. You will be late that day. Everybody be angry, but only you can stop this nonsense of other physicians passing them along the line. The truth always comes out. You can do this. Always. You can always make a diagnosis. It's nice to have a family member confirm a pulse. This may take a second visit. Much of this you can do on the first visit. But you have to think about the strategy for the second visit. Next, they always have biological syncope, so they're always going to be a little confused and a little confusing because you have 2 histories going on. One, the symptoms around biological syncope, and the other, the symptoms around their conversion collapses. So you start again with the seizure stuff. You start with what you're comfortable with, the biological syncope. You build up a repertoire for them, a pattern, so they understand what that is. And then you move on to present day. Find out how long it was when they were well, and then when things started to go south. And it's abrupt, really, it happens overnight. And it's at least weekly, sometimes 10 or 20 times a day. I'm not making this up, and it's not uncommon. And then you just ask them, okay, are these all the same? I will stop soon, but they're never going to see this again. They don't have a prodrome. They just go down. They go down gently. There is a bit of injury, but not as much as you'd expect. Some are quite long, not all. It's all over the place. They're not tired afterwards. They're not sweaty or pale. There are no biological signs, and their eyes are usually closed. They collapse like an angel. If you just get through that, you'll either know what it is or you'll be pretty sure. And if you're uncertain, somehow get them to get a blood pressure at home during these things. Over half of Canadian households, and it's probably the same in the States, have home blood pressure machines. It's amazing. I don't know what they do with them, but almost everybody's got one. And so if they're going to be down for minutes, that's time to get a blood pressure. Cell phones are helpful as well. If you are certain, eventually you will be. Sometimes you're certain before you think they can be certain, and you have to sort of move them along. Then move on to the mechanism. And you can almost always get a mechanism on the first day and often the second. And that's you have to be very subtle with this, but it always comes out. Just have them talk about their life, and then, how's it been the last 5 years? So what happened around 6 months ago or so? And there's something will have happened. The big traps for the patients, the things this intractable stuff that they've got, prolonged psychological abuse, sexual assault, usually repeated, usually ignored by everybody, including the police. Difficult work in school environments, that's the boys. Prolonged intractable health problems. And for the type 2s, just something very brief. that's how I can send the slides if you want. Thank you.